In Singapore, what is driving up hospital bed occupancy is the increased number of seniors with complex conditions. Post-COVID, and we saw a surge in the numbers. I reported to the House earlier that average stay in hospital went up from about 6 days to 7 days, pre and post-COVID. And that alone represents a 15% increase in patient load. To tackle the challenge more fundamentally, we need to expand capacity and catch up the time lost due to COVID-19 pandemic. We opened about 640 new acute and community hospital beds since June last year. They make up the over 11,000 public hospital beds that we have today. That's the stock we have, 11,000. We intend to add another 4,000 beds by 2030. And we should see new capacity coming on stream every year from now to 2030. Start with this year and next. 2024, 2025, Woodlands Health will commission up to 700 beds. 2026, Sengkang General Hospital and Outram Community Hospital are expected to expand by about 350 beds by converting non-clinical areas into hospital wards. Then 2027, the elective care center at SGH is expected to open. That has 300 beds. 2028, 2029, the redeveloped Alexandra Hospital is expected to open progressively. Then 2029, 2030, the new Eastern General Hospital campus is expected to open progressively. Then we move into early 2030s. That is when we hope to see the completion of a new regional public hospital that we have started work on. We have just completed one in the north, Woodlands Health. We are building another one in the east. We are expanding SGH in the central region. So the next new public hospital should be in the west. We are planning to site it in Teng Nga Town, which is an emerging population center. It will best complement current hospitals in the west. The new hospital in Teng Nga will be run by the National University Health System Cluster. Mr. Ang Wei Nen nodding his head. Notwithstanding this plan to expand capacity, we should not be trapped in the mindset of building hospitals when thinking about capacity. There is potential to better anchor care outside of hospitals in the community. Not all patients require high acuity care and constant monitoring in a hospital throughout their treatment course. Many need convalescent care and rehabilitation with the assurance that medical help is readily available nearby. That is why we have built more community hospitals for subacute and rehab patients and transitional care facilities for patients who are waiting for longer-term care arrangements. With our efforts, the number of long-staying patients have come down. And these are patients defined as medically stable for discharge, but they have been staying in hospitals while waiting for longer-term care, and they have been staying for longer than 21 days. This is what we refer to as long-staying patients. 2 years ago, it was about 300 such patients at any one time in our hospital system. Now it is under 200 patients at any one time, and there is still room for improvement. To facilitate appropriate transfers from acute hospitals to community settings, we will also be making a few policy changes as follows. 1, more funding for community hospitals. Acute hospitals have experienced friction in transferring suitable patients to community hospitals. Why? For example, certain diagnostic services, such as CT and MRI scans, and certain more expensive drugs are not subsidized in community hospitals today. This is based on the consideration that these are recovering patients and they may not need these interventions. Unfortunately, this means operational delays in transferring patients to community hospitals. There are patients who are medically ready to be transferred, but they're just waiting for a follow-up scan. they should be transferred without delay and do the scan at the community hospitals. Others worry that after transfer, what is unexpectedly, I need a scan for some reason. Hence, they insist on staying in the acute hospital just in case. To remove this friction from the last quarter of this year, we will allow more diagnostic services like CT and MRI scans and relevant drugs to be subsidized at community hospitals. More broadly, we will also align the community hospital subsidy framework to the acute hospital subsidy framework. It used to be different. That way, patients receive the same subsidy rate, which is 50 to 80%, throughout their inpatient stay, regardless of settings. And with this enhancement, most community hospital patients will see smaller hospital bills. Second change is make mobile inpatient care at home, or MIC at home, a mainstream service. What is MIC at home? This is a pilot project where we set up virtual hospital beds at the homes of patients and have doctors and nurses visit them as if they are in a hospital. Dr. Tan Wu Ming, Mr. Pritam Singh, Ms. Ng Ling Ling, and Ms. Mariam Jafar have asked or talked about such a scheme. At the end of last year, more than 2,000 patients have benefited from this scheme. This translates to around 9,000 hospital bed days saved. Having done this for several months, we are convinced that the scheme works well for the patients and has great potential to relieve stress at hospitals. Hence, from April this year, MIC at home will become a mainstream model of care in our public healthcare institutions. So as a result, patients can be assured that they will not pay any more for MIC at home than they do for acute inpatient care in a public hospital. All our hospitals intend to price MIC at home similar to or lower than a normal hospital ward. Patients will be supported by subsidies, MediShield Life, and MediSave, no different from a physical inpatient stay. In response to Associate Professor Jamie Lim's suggestion, I don't think we therefore need to give an incentive for transition to home care now. It will be better to develop MIC at home into a well-accepted mainstream mode for acute inpatient care. We will also further expand the capacity of MIC at home as a first step from 100 in 2023 to 300 in 2024, with the potential to scale up further. Third change is to encourage telehealth. 40% of attendances in the typical polyclinic are for chronic care management. Last year, we extended subsidies and allowed the use of MediSave for the use of telehealth for chronic care. By the second half of this year, we will also expand MediSave coverage to telehealth consults for preventive care, such as follow-up reviews after regular health screening. This represents another 10% of polyclinic attendances. With this change, telehealth is treated almost the same way as physical consultations in terms of financial support. The only difference is telehealth for common illnesses. That is, when patients experience symptoms like cough, cold, fever.